Welcome to all those in the U.S. and around the world. Almost 400 people signed up for this event, and I want to thank you for joining us. My name is Ed Stever. I'm president of the National Foundation of Swallowing Disorders. I'm also a head and neck cancer survivor with severe dysphagia. Our mission is to provide patient hope and improve the quality of life for those suffering from all types of swallowing disorders. And we do that with 4 supporting pillars: providing direct patient support, hosting educational events, increasing dysphagia awareness, and supporting promising research. And I'd like to just focus on a few of those briefly. In the area of direct patient support, we provide referrals to 15 to 20 people per month to qualified healthcare professionals worldwide. We also host or have organized 15 in-person support groups that are ongoing and have 2 forums on Facebook, one for pediatrics and the other for adults. And the pediatric forum is very active with almost 1,000 posts and comments per month. It's created quite a community. In the area of education, we host events similar to this. This is actually our 27th webinar or live event over the past 4 years, most with world recognized industry leaders in the field of swallowing disorders. We increase awareness, meetings at NIH, congressional representatives, and promote promising research, and even fund our own research, such as the cost burden of dysphagia on society in general. You will be muted during the presentation, but this is a great opportunity for you to ask questions along the way. All you need to do is click on the blue question mark and type in your question, and Samantha and Michelle will get to it during their presentation. Given today's webinar topic on the impact of dysphagia on caregivers and family, this felt like a good time to honor Michael Donovan, who is one of the co-founders of our foundation. He was diagnosed with head and neck cancer at age 37 and lived a life he loved until head and neck cancer ended his life last year, 22 years after his initial diagnosis. His family played a huge role in supporting Michael through his journey. It's tough remaining an optimist and being independent when experiencing so much trauma. He was one of the most optimistic people I knew, and I attribute part of that to the support he received from his family. Michael left a gift to the foundation that will live on for years to come, and we should all be thankful for who he was, who he impacted, and his generosity. So thank you, Michael. Today's webinar is free. We have two sponsors to thank for their generosity. Simphil, a new sponsor, developed a product to make pill swallowing easier, and Bracco Diagnostics, who has sponsored the foundation generously for years with an unrestricted educational grant. Samantha Shune is an assistant professor at the University of Oregon. I saw her present last March at the Dysphagia Research Society annual conference and thought she'd make an outstanding foundation webinar speaker. Samantha suggested she co-present on the topic with a fellow SLP, Michelle Vandehei. Michelle completed her thesis at Idaho State University, but more important in the context of today's topic, she provided support to her father, a stroke survivor with severe dysphagia. She agreed to share her experience as a caregiver along with her educational focus. Both Samantha and Michelle have volunteered their time to be here with us. And at this time, I'd like to turn this over to our keynote speakers.
Greetings, everyone. I'd like to just introduce and say hello again. So my name is Samantha Shune. I am from the University of Oregon, and I am going to get my slides going up here. And next to me, I have Michelle Vandehei.
Hello.
She will be speaking a little bit later in the second half of the presentation. And we are just very honored to have the opportunity to speak to you all today about dysphagia's broader impacts on caregivers and families. Before we start, I did just want to present our financial disclosures. Some of the research that I will be talking about today was funded by the American Speech, Language, and Hearing Association. So I wanted to start with this quote from Being Mortal by Atul Gawande, and I will go ahead and read it to you all. So the job of any doctor, Dr. Bludow later told me, is to support quality of life, by which he meant two things: as much freedom from the ravages of disease as possible, and the retention of enough function for active engagement in the world. Most doctors treat disease and figure that the rest will take care of itself. And what I really like about this quote is it's very reflective of what the World Health Organization and the NIH feel about rehabilitation as well. So according to these organizations, rehabilitation of people with disabilities is a process aimed at enabling them to reach and maintain their optimal physical, sensory, intellectual, psychological, and social functional levels. The goals of rehabilitation are to help survivors become as independent as possible and to attain the best possible quality of life. So what does this mean in the context of eating and swallowing? And what does this mean for dysphagia treatment? I did a very scientific search done on Google Images, and I typed in the words eat, eating, mealtime, and food, and these were among the top 10 results that were returned. And this makes sense, right? Shared meals reinforce our physical, psychological, and emotional connections to ourselves and to others around us. And really, as human beings, we tend to connect food to rituals, to symbols, to beliefs, and it allows us to reaffirm, transform, and maintain our relationships through the shared meal and through the food experience. We also know that meal times are a cultural site for the socialization of individuals, particularly children, into appropriate and competent members of society. But what happens when someone does have dysphagia or when someone does have difficulty swallowing? So, doing my same scientific Google Images search, I typed in the word dysphagia, and these were the top 5 images that appeared. We no longer see the person, we no longer see the family. We're very much reduced to the swallowing system and the physiology of swallowing itself. So ultimately, what my research program is aimed at is moving from this kind of static image of a dysphagia assessment, this very still image of impairment, and putting that impairment within the whole person themselves. And taking it one step further, and of relevance to today's talk, is really then putting that impairment that's within an individual person into the family. And what does that mean for the family system? So I want to take a moment and talk about the family caregiver. Pretty soon, we are going to have a healthcare system that won't be holding people longer than 24 hours. We actually already are seeing patients being discharged from acute facilities much sooner than was previously true. So in fact, our healthcare system actually relies on the efforts of informal caregivers to the tune of saving the American healthcare system approximately $350 billion annually. This unpaid care is actually of the utmost importance. So we know that supporting individuals to live at home, despite the presence of medical conditions that may prevent them from being able to independently care for themselves, is really hugely beneficial. Care recipients that reside at home have a significant reduction in mortality rates. They have increased feelings of security and familiarity, and they are better able to maintain informal relationships and interactions, all of which promote improved quality of life. Unfortunately, though, informal caregivers do experience higher levels of emotional, financial, and physical difficulties, which ultimately impact their overall health. As a consequence of caregiving, these family members often suffer from symptoms of depression, symptoms of anxiety. They even can demonstrate decreased immunity. Caregivers further are less likely to monitor their own health, which can contribute to decreased overall well-being. So in fact, caregivers may be the most vulnerable member of a family. We also know that poor caregiver well-being can negatively impact care recipient health, and thus the cycle continues. Ultimately, the physical health and quality of life of both the caregiver and the care recipient are interdependent. That means that our current model of care is really not sustainable as it is currently practiced. Informal caregivers are not only members of the support team, but they're also individuals with their own needs. Reducing sources of burden, therefore, is a priority. However, prior to intervening, we must first identify those risk factors that do potentially increase caregiver burden. I think, unfortunately, as clinicians, we may be contributing to such burden. So often we are focused on the impairment itself and the supports that a patient needs to be successful. So this infographic here, I really like it. It was put out by ASHA, I believe, last May is Better Speech and Hearing Month, and it highlights all the valuable roles that families and friends and other members of the community can play for an individual who has a swallowing disorder. So we can be a supporter, we can be an advocate, we can be a trainer, we can be a chef, we can be a recorder, we can be a companion. Yet this is a lot of roles to fill. It is clear that we are placing high demands on those caregivers who are providing the support to our patients. And I think at this point, we're not entirely sure what consequences result from these increased demands. So I want to take a moment and introduce the concept of third-party disability for those of you that may be less familiar with this idea. And really, where this idea stems from is that the impact of a chronic medical diagnosis on daily life reverberates within an entire family system. So, as challenges and uncertainties associated with that given condition extend into the distant future and continue into that chronic stage, a serious psychosocial strain on the family unit is often unavoidable. So, the International Classification of Functioning, Disability, and Health has allowed us to frame dysphagia's biomedical effects within a larger psychosocial context. So, that is on an individual person, how does dysphagia impact their activities and participation in daily life? It actually may be equally as valuable to document the influence of a patient's dysphagia on her or his social context. So for those of you who haven't seen the ICF framework before, here's a basic schematic of it. And it really defines functioning from the perspective of, we'll see if my mouse works here, from the body. So that's the impairment level. And then the individual and society. So the activity and participation within society and within daily life. It allows the user of the framework or model to describe the consequences of a health condition on an individual in the context of their environment. So in the example of dysphagia, the presence of aspiration would be an issue here with the body function. Patient reports of reduced social activities due to their dysphagia would fall under activities and participation. And then the need for support from caregivers regarding, say, mealtime preparation would be here under the environmental factors. So as I said, this might be an important framework for looking at how dysphagia is impacting the larger family system. And Nund and colleagues have delineated the third-party disability that's experienced by caregivers of individuals with dysphagia within this ICF framework. Notably, this research and other studies that I'll talk about in a moment have suggested that dysphagia results in widespread activity limitations and participation restrictions, specifically among the caregivers and family members of the individuals with dysphagia. So in other words, the caregivers and family members are experiencing a disability in the absence of their own health condition. So what are some of the things that have been found regarding caregiving and dysphagia? The previous research has actually suggested that swallowing impairments may contribute to the burden of individuals with head and neck cancer and neurologic diseases such as stroke. So the previous research has found that family members of individuals with dysphagia experience increased feelings of anxiety, burden, distress, fear, frustration, sadness, and isolation. They often talk about a loss of social bonds and feeling decreased life satisfaction and decreased quality of life. Overall, many of these caregivers and family members talk about having to negotiate a new normal. So it's adapting and coping with this new normal, their new normal daily life. Some of our recent work, has actually taken it a step further. So while the previous work in dysphagia has characterized the challenges associated for caring with an individual with dysphagia, our recent research is actually the first to systematically identify dysphagia's independent contribution to more global caregiver burden in light of other burden-related risk factors. And what we have found is that the third-party disability experienced by caregivers of individuals with dysphagia is actually a consequence, at least in part, of the presence of dysphagia itself. So I'm going to talk about a series of 2 studies now that we've been working on in my lab in conjunction with Dr. Namasivaya McDonald at Adelphi. And the data for these studies were extracted from 2 linked population-based surveys. So there's the National Health and Aging Trends Study and its companion study, the National Study of Caregiving. The NHATS and NSOC studies are nationally representative longitudinal studies that use in-person interviewing to gather information about overall health and well-being of over 8,000 Medicare recipients aged 65 and older, as well as their caregivers. So we completed recently two cross-sectional studies to really determine the type and extent of burden. So we looked at emotional burden, financial burden, and physical burden experienced by spousal caregivers and children caregivers of older adults with dysphagia. So in the first study, we had 422 community dwelling older adult spousal dyads. Within that subset, 17% did report having swallowing difficulties. And then the second study had 895 community dwelling older adult children dyads, so children caring for their aging parents. And in that subset, about 20% self-reported that they had swallowing difficulties. What we found is that when we controlled for other factors known to influence caregiver burden, dysphagia actually was an independent predictor of increased emotional burden for both groups of caregivers. So caregivers of spouses with dysphagia were more than 2 times more likely to experience emotional burden than caregivers of spouses without dysphagia. Similarly, caregivers of parents with dysphagia were over 1.6 times more likely to experience emotional burden as compared to caregivers of parents without dysphagia. Of further note, this rated emotional difficulty was not benign. If you look at the numbers here, for both the emotional difficulty within the within the children caregivers and the emotional difficulty within the spousal caregivers, for the most part, it was in the moderate to severe range of to what extent are you experiencing emotional burden. Similarly, we also looked at physical burden, and when controlling for those other factors known to influence caregiver burden, dysphagia again was an independent predictor of increased physical burden among caregivers of parents with dysphagia. And these caregivers were over 1.7 times more likely to say, yes, I do experience physical burden. And again, the physical burden was in that moderate to severe range. Financial burden did not come out with dysphagia as an independent predictor, so I've not reported on that here. So I always say this is kind of my mic drop moment, so I will put my mic drop up there. So what dysphagia actually independently contributes to increased burden among informal caregivers, in this case of older adults. And this is even when controlling for factors that are known to influence caregiver burden in the more general literature. So what do we do with this information? What does it mean? I think the first thing that this points to is that really, in order to help mitigate the burden felt by caregivers of individuals with dysphagia, it becomes crucially important that healthcare professionals identify swallowing impairments early on and we treat them. Before the burden becomes too much to bear, we need to be getting in there and addressing the swallowing dysfunction and know that the swallowing dysfunction is present. We also need better methods for being able to identify the presence of caregiver burden and being able to say, whoa, is this too much that we're putting on you, or how are you handling this? The other thing that I think this points to is the presence of better caregiver support. So as we think about the field of implementation science, it's clear that in order to maximize intervention outcomes, we really must consider more comprehensive management approaches that ensure that caregivers have the tools they need to support our patients and that they themselves feel supported as caregivers. So this is where I'm going to pause for a moment and put in plug number 1 for current research studies that we have going on. And actually our lab, in combination with the lab at Adelphi, we are currently working on a tool, a screener tool to screen for caregiver burden, specifically as related to dysphagia and swallowing disorders. And so what you'll notice in the handouts we've provided, I've given you a number of flyers about our different research studies. And so that flyer is in there. Really what we think we need to be able to do is have some quick, easy screener to then say, okay, we're noticing perhaps an increase in burden. We're noticing some new feelings of burden being present in the caregiver. So we really hope that you can help us spread the word on that study. The flyer has a link right to the survey, so feel free to check that out, and it's only about a 10 or 15 minute survey to complete. All right, hopefully you are all still with me because that actually isn't the end of the story. So I think we've done or we're doing a better job of talking to the patient and saying, how are you doing? Beyond your impairment, beyond your dysphagia itself, how are you doing? Hopefully, after today, and I think as some of the literature points to, we're starting to do a better job of talking to the caregiver and say, okay, how are you doing? I think where we're still not at yet, though, is talking to the family and saying, how are you doing as a family? Really supporting this idea of joint family health. Other factors that were found to be associated with caregiver burden in the two studies that I just mentioned included care recipient and caregiver arguing and other family members disagreeing with care decisions being made. So there's certainly something happening at that family relational level that I think we need to do a better job of capturing in order to make sure that we are providing the best care we possibly can. So then, revisiting our third-party disability model from earlier, not only can dysphagia impact a caregiver's functioning, activities, and participation, but really caregivers' third-party disability can in turn influence patient outcomes. Ultimately, the health and well-being of both members of the caregiving dyad are intricately linked. So this will be where I'll pause, put in plug number 2 for research studies. So again, you'll see in the handouts, we have 2 other studies that are going on that are really geared at addressing this question here. How does the presence of dysphagia influence overall family dynamics and influence the family as one unit? So we have a number of studies occurring, in this case specifically related to the stroke population, to take a look at what does the impact of post-stroke dysphagia have on the family system and family relationships. I think what this all means is that really we need to be taking a paradigm shift. We need a paradigm shift. We need to be operating under the premise that chronic illness and disability are universal human experiences that fundamentally alter the everyday lives and psychosocial well-being of the entire family. Such illness and disability alter routines, communication, belief systems, caretaking patterns, and family decision making. Because ultimately, when one member of a family system faces a chronic health condition, the entire family system is simultaneously and reciprocally impacted. So, as individuals experience healthcare challenges, their entire family system simultaneously has to adapt and cope. So what I want to spend the rest of my time of this presentation doing is introducing you to a framework that can help guide our practices in dysphagia management as well as clinical care more broadly. So I'm going to talk about the biopsychosocial spiritual framework or model. This was introduced by John Rowland from the psychiatry and collaborative family healthcare fields. And really this framework appears a lot in health psychology and couples and family therapy. And so this interdisciplinary model aims to provide clinicians and family with a way of thinking that promotes agency and empowerment over a complex and long-term process such as chronic illness. And I want you to highlight that word agency. If anything you take from this slide, it's highlighting that concept of agency. Medical family therapy really endorses patient and family agency and facilitators of health communication between the healthcare team. So they're often asking questions, does everyone feel respected? Does everyone feel heard on the team, specifically patients and family members? Is there a clear plan moving forward that everyone shared in the conceptualization of? And what are the goals of the collaboration? Because ultimately, we want patients and families to know that they have a say and have agency in their healthcare relationships. So let's put this in context. I'd like to introduce you to Hong. She's in the center here and she is surrounded by her family. So her husband, her 2 children, and her parents. And now let's say one day Hong has a stroke. Suddenly, this picture of her family system gets replaced as our healthcare systems tend to focus more on the individual and the illness, but not on the family. And in fact, I would argue that the healthcare system then even fragments patient care. So our single person, our individual patient here becomes What's wrong with her brain? What's maybe wrong with her ears or her hearing? What's wrong with her swallow? What's wrong with her lips? What's wrong with her lungs? And so we've really now moved very far away from that initial picture that we saw of Hong sitting in the middle of her entire family. So the biopsychosocial spiritual framework, these are the model components. And so we see three interlaced circles here. So at the center, we have the type of illness, disability, or loss. Then we have the individual, family, or illness life cycles, and then the belief systems, culture, and ethnicity. So taking our example with Hong there, maybe she had her stroke 9 months ago. She had acute severe dysphagia in the initial stages of recovery, and now it's chronic moderate dysphagia. She has had a recent plateau in therapy. She's still on a texture modified food diet. And we know dysphagia doesn't often occur in isolation, so perhaps she has moderate expressive aphasia as well. And her receptive skills, though, are relatively intact. Moving to the next level, perhaps she was working part-time while being the primary caregiver of her young children. Her parents recently moved in with her due to their declining health as they were aging. She was previously responsible for all household tasks. Many people described her as the glue of her family. And given her life demands, working part-time, raising her small children, taking care of her family and her parents, she currently has a small social circle, which is something to consider when we're putting demands on caregivers and family. Who else is available to help? It's also important to think about some positives and some strengths, not just impairments. So she shares with her husband mutual enjoyment for crossword puzzles, puns, and artsy movies. Also, she has a strong nonverbal connection and communication with her husband. People could always feel their love. Moving even more broadly, it's this concept of invisible disability. Physically, she looks fine. Dysphagia, swallowing problems, and aphasia, language problems, are often an invisible disability. People often associate language with intelligence and coughing with something that's gross. So what are the stereotypes that exist that are related to the difficulties that she is experiencing? And finally, culturally, daughters take care of their parents and wives take care of their families. And this has now been disrupted in the presence of her stroke. So what this really points to is that ultimately we need a model that looks at families dealing with illness through a more normative lens. And this model is really intended for interdisciplinary use. So I know we have a number of clinicians listening in today, and I don't want to sit here and say these are things that only a speech language pathologist should or can or must be doing. But this model is really intended for an interdisciplinary use in thinking about how we can address an entire person within their family system, working and collaborating with other healthcare providers. So I want to end my section of this presentation with a quote that I have from a participant in one of my other studies. And I'm going to take a moment and read it to you. So it does put a lot of strain on our relationship. There are times that I just resent the hell out of it. He used to do things. He cooked for me and he cleaned for me and he kept the yard in shape and he did things. Some days I get home and the house looks like it exploded. He has this serious left side cognitive issue. He just doesn't notice things on his left. And sometimes I come home from work and the house just looks like an explosion. I've always been super clean, super neat, a little OCD about that. I'll own that. And I've had to let that go, but it doesn't make me comfortable. I get home and I'm like, what the hell? You ran the dishwasher with one plate? Or you did a load of laundry and the only thing that's in there is a sock? So I've had to learn. And actually, I haven't learned. I struggle with it. When is it okay to say something and when do I just let it go? I have to check myself constantly and think, am I saying this because I think it's going to benefit him? Or am I saying it because I'm just frustrated? There is definitely a very large gray area there. Well, and oops, sorry, I wasn't sure my screen disappeared for a moment. We'll go back for a second. There we go. Well, and my part of it is that I'm not a very good care receiver, the patient then goes on to say, and the caregiver continues. Oh, yeah, he'd much rather do it himself. It's tough. It's tough on both of us. He has always been fiercely independent, and I've never once heard him say, why did this happen to me? I've never heard him once behave like a martyr, try to place blame, try to say things were unfair, which is very different for me. Do I want the man back that can mow the lawn and do all that stuff? Absolutely, I do. I'd be crazy not to want that back. But is that realistic? Probably not. It hasn't affected how much I love him. We just have a new normal. So at the end of the day, if all we have sitting in front of us in the therapy room is the patient and all we are focusing our assessments and treatments on is the impairment level needs of that patient, we are missing a huge piece of the bigger picture and ultimately reducing the potential real world impact of our services. Even worse, we may actually be increasing burden and decreasing family well-being. So I'm going to pause for a moment here, and Michelle is going to begin her portion of the talk in a minute, but we thought this might be a nice opportunity. If anyone had a few preliminary questions, I'm happy to take some now, and we certainly will have time at the end for questions for both of us as well. So I'll pause for a minute and we'll see if there's any questions. Yeah.
Excellent. Samantha, thank you so much for sharing that. We have a few questions that came in. The first one that I'll start with is going back to the studies that you presented where you were comparing what it's like to be a spouse of someone with dysphagia versus a child of someone caring for their parent with dysphagia. The question was, what category would siblings fall into?
Yeah, I mean, that's a great question, and that's not something that we've looked into yet. I think, it's a very unique category certainly to be in because it's a very different relationship that one might have, and especially I'm not sure if the question's coming from sibling of a younger individual with dysphagia, like a child, versus an adult sibling of an individual with dysphagia. But I think anytime you're changing a typical relationship, that's where I think some of this burden comes from also. For example, in the case where a child is now caring for their parent, that's a reversal of roles that people aren't used to. I would expect a similar thing to happen with siblings as well. Siblings, you're supposed to have this kind of equal relationship. You're on the same ground, you're going through the same things. And so when you start getting a bit of a hierarchical structure in there, like I am taking care of you, that can certainly change things. But that's a great point and something that we will definitely consider looking at in the future as well.
Thanks. I have another question here for you. It's from a mother of a little one with dysphagia. I'm going to read part of her story here. It says, my daughter is 8 months and she was put on honey thick liquids at 6 weeks due to severe color changes with every feeding, where her oxygen would drop into the 50s. She had a swallow study that showed aspiration with everything but honey thick liquids. And then she had another swallow study a month ago where she passed for thin liquids. The mother's been breastfeeding since then, but she's noticing that her baby still is coughing and choking with every feeding. She's feeling drained and she doesn't know where to go from here. Wondering what suggestions you might have clinically, and I think also just for support for this young mom.
Yeah, I mean, I would say from the clinical standpoint too, you shouldn't have to be concerned about that coughing and choking and have that concern by yourself. I mean, I certainly would reach out to the clinicians that you were working with before, the speech language pathologists, the physicians, because that fear is real and you're noticing something happening. And, on one hand, you certainly want to get that addressed and make sure that it's not actually something, going on and talk to your clinician about that. But I do think that fear is something that doesn't necessarily go away immediately. And I know Michelle is going to talk a little bit in her presentation about how you do adapt to the new circumstances and what comes up and how you can emotionally deal with it. And I don't want to steal your fire, but if you want to just mention, counseling and some things that helped you.
Yeah, I think as a family, and I'll of course get into that, but when we first, when it was acute and my dad was aspirating everything, there was a lot more fear associated. And kind of as we got the counseling through speech pathology, our speech pathologist, and then Ultimately, as a family, once we found some counseling services, it was really helpful to be able to kind of dissipate that fear and sort of be able to, play out the outcomes of what would happen if he did choke. If he aspirates sometimes, is it okay, versus, what do I need to look for, and what kinds of things do I need to go back to the doctor for, probably in a little one, would be really important.
And I would say too, I really appreciate you sharing your story, and I hope that the clinicians who are listening in can take that story to heart too, because that's precisely what we hope doesn't happen. We don't want caregivers to feel burnt out. We don't want caregivers to feel emotionally drained and feel like they don't have professionals supporting them in that process.
Samantha, I'm going to ask one more question, and maybe this question is best saved for the end. I'll let you two decide that.
Okay.
The question is, what approach is best when one or two family members either disagree with the treatment approach or are disinterested in being involved in the process altogether?
Maybe let's ask that question again at the end, after we've had a chance to talk about the family experience. So we'll come back to that one for sure.
Right, sounds good, and we'll save the rest for the end. Thank you.
Okay, so I'm going to switch over to Michelle now. So just give us one moment to switch our spots here.
Okay. So thank you for the introduction earlier, and I also wanted to thank the foundation for the opportunity to get to speak to so many people. I'm really honored to have this platform for the opportunity to speak kind of my truth about being a family member of a person with dysphagia, and then also my other hat of being a medical speech-language pathologist. So I'm going to give you some insights into my story, which certainly my disclaimer is that it's not everyone's story. And so what works for you and for families, go with that, of course. So if something I say doesn't resonate with you, I wouldn't use it. So my argument is that people with dysphagia and their families oftentimes don't have a seat at the table, both figuratively and literally. So I'm going to launch into some stories that I have to support this. So I can't really get started without, oops, I'm going to back up, sorry. So recently I was out in the community, and there was a woman I was talking with, and she was asking about what I did as a speech-language pathologist. And I told her that I worked with adults with swallowing issues. And she proceeded to tell me that she knew a gentleman who had dysphagia in her assisted living, and that, he was having trouble and things were spilling out of his mouth, and it was so unfortunate. And I really felt like she got it. Like, I felt like she understood. She had the words behind it. She knew the lingo. And then she proceeded to say that it was unfair for everyone around him because he was a messy eater and they shouldn't be subject to that. And I realized he didn't have a seat at the table. And ultimately, what made me so upset about this was that my dad, certainly after his stroke, didn't have a seat at the table, and we often didn't either. So there's deep-rooted social norms, as Samantha touched on, that we agree to when we sit down for a meal. So if any of you have ever been to a restaurant, of course you have, you agree to be cleanly and to be, a certain volume and to only do certain things in a restaurant. But let's say someone spills their drink. Everybody turns to stare, and oftentimes people whisper to one another, oh, they just spilled their drink, that's so inappropriate, and they're hushing each other. And I would argue that's how it feels to go to dinner with someone with dysphagia. They're coughing, they're choking, sometimes they turn red in the face, sometimes they have labial spillage and there's things all over the floor. So just, being mindful that they don't have that seat at the table anymore. So I should give some background. As clinicians, I feel it's crucial to understand who people are and who they were by the time they get to us. So I find the background to be equally as important as where I'm going with this. So I'd like to provide you some history about my dad prior to his stroke. So he was a logger, a very proud man. he had one of the most demanding jobs on the planet. He was a timber faller, which in that culture is a coveted thing. And I guess he did it well, so I've heard. He started one of the largest companies in Oregon, which is on Axemen apparently, and then broke off to, to continue his own legacy by acquiring land for our family. And in the interim, part of their culture, and this is what I'm getting at, loggers have their own culture. Every morning he would get up and go to breakfast with his friends and talk about whatever it was that loggers talk about. And it got to the point that I knew this restaurant so well as his child that I was able to shout at the waiter my order if my chocolate chip pancake wasn't made just so. He was a man's man by all stretches, and at that time, he certainly had a seat at the table, and arguably often with his charisma was at the head of the table. So what changed in that amount of time? We chronicled our lives pre and post stroke, and I've heard that that can be difficult, but realistically, dysphagia and his stroke caused us to not only have two different chapters in our lives, but I would argue that they were two different books. And here's a little bit of his journey. So my dad had a stroke in March of 1999, an ischemic stroke. He would have made what they said to be a 95% recovery. However, he did need to have surgery to clear some blockage in his carotid arteries. Surgery went well until it didn't. 3 days post-surgery, he had a massive hemorrhagic stroke in the basal ganglia, which ultimately landed him in the ICU, essentially fighting for his life. Now, if you do a quick Google search of a hemorrhagic stroke, 25.7% is the survival rate in 2019. And in 1999, we knew even less about the brain and even less about stroke. So I want to mention in these pictures before I move forward, that life didn't just stop for us that day. It did, and then it moved on. So as you can see here, as Samantha touched on, that first picture to me is a perfect example, actually, of what a person with dysphagia looks like. And he participated in everything in our lives. So your life doesn't stop. You have to find a way to move forward. So moving forward, let's back up first. So at the time, my mom was 45 years old. My dad was 52. I was the youngest of 3 children at 7 years old. So we had to come into the ICU to say goodbye the first night because the doctors didn't think he'd be able to regulate his body temperature well enough that he would have a survival. Clearly, I wouldn't be talking to you today if he didn't survive, so that's the good news. And my mom chose in-home care. And in the interim, from when he was in the ICU that first night to when he came home, he was unable to swallow his own secretions and ultimately had to have a trach placed. And then he had to have a feeding tube also placed, a PEG tube. He had extensive rehabilitation, inpatient rehabilitation followed by coming home, which was not their first choice. But my mom refused to send him to skilled nursing and refused long-term care just because that wasn't what was best for him. I can remember as a child getting off the bus, and there was a period of time between when my mom would get home from her full-time job and when my dad needed his tube feedings. So once the caregiver left, of course, we watched the Maury show, which was not appropriate. And then we proceeded to help my dad with his tube feedings. We also knew that if his sputum came out of his trach, we were to wipe that and make sure, that his stoma was cleaned. Some people couldn't handle this in our lives, and that's just part of the reality as family members of people with dysphagia. It can be very painful. In fact, my mom had a phone call from my dad's best man at their wedding, who told her that he just couldn't remember my dad this way and needed to remember him as he was. So we were able to get a prognosis of 5 years, and he ended up living for 19 years. So for 2/3 of my life, I lived with someone with severe dysphagia, and he died at the age of 72, nearly 20 years after his initial stroke. And I'm happy to say, and as a speech pathologist, proud to say, it was not from aspiration pneumonia or from a fixation. It was complications cardiac related. My dad had a superstar, a complete rock star who I considered to be his speech language pathologist, And I felt like she really understood patient and family-centered approach before that was even a buzzword. And in doing so, she inspired me to become an SLP myself. So swallowing was so important to my family that I wanted this to be my legacy, and I chose to go into the field. He was able to get the trach and peg out eventually, and at some point was placed on a mechanical soft diet with nectar-thick liquids. However, unfortunately for us, or fortunately, I don't know, he was a very stubborn man, which didn't change, and his love for food didn't change either. So he ended up eating most of the time things that were inappropriate for his diet texture. So I'm going to show you something. So it may seem like 19 years later I'm far removed, but I wanted to provide the perspective of what it's like to be a child with this dysphagia. So here's one of my journal entries from when I was a child. And I'd like to point out that I am a millennial, and there was a period in our education in which they didn't encourage spelling. So I'll translate it for you. It's dated the 7th of October, 1999. My dad did the barium test yesterday. My mom said that it was pretty gross for my dad. But the good news is that if the doctor agrees with the speech pathologist, my dad could get the trach out. My dad could talk again. My dad still has it. So if any of you are doubting that there are in fact impacts on the primary caregiver, I'm here to tell you that they do in fact feel the disability as well. And even further than that, I would argue most people in the family unit have the potential to feel the impacts. And I would say as our clinicians, it's our role to recognize that his speech pathologist is in this note because she made a difference for our family. And we really have the opportunity as professionals to make a big difference and to be the people who really care when no one else perhaps does. So as a clinician and a family member with dysphagia, I want to provide you with some reasons that I think people aren't getting a seat at the table and some examples of how that feels from my own life. I think our healthcare system often is not working with families enough to make sure that they're getting the support they need in order to be able to be successful. We need to acknowledge that our roles as caregivers and as healthcare professionals is to extend beyond just the impairment. And here is the firsthand account of how that feels. So some of the implications for families are increased social isolation. So me specifically, as you saw, my journal entries were quite different maybe from most first and second graders. And I felt that. So oftentimes I was writing about my dad's stroke. In fact, I had several journal articles in that same journal that talked about his feeding tube being infected or not having enough support. And most other people were talking about what they had for lunch or recess, or their puppies and kittens, which I had some of that in mind too. But I realized that it was really hard to relate to my peers. So so my friend once said to me, like, well, my dog died, to try to relate to my dad having a trach and a peg tube. And I realized from a really early age that it would be a very long time before my peers understood what I was going through, if they ever really understood at all. And that's a really lonely feeling. So I think other families can have that same isolation. And there's examples of that. So my mom often would get invitations to our house directed for us, but it was to her only, or to her and the kids, and dad would be completely left out. Why? Because dysphagia is uncomfortable. People aren't comfortable with someone sitting at their table choking. He didn't get a seat at the table. And at times we didn't either. So there were birthday parties, that we didn't get invited to, or weddings. And, my friend group, even as a young child, their parents would get together for dinner parties, and my dad would often be excluded, and we wouldn't get invited either. So socially, I always felt a little bit left out, because then at school, they would talk about this fun dinner party they had. And my family just wasn't a part of that. And for a while, I thought maybe they just didn't like us enough. But I came to realize we were just different. So the other plug for judgment in healthcare is really important. I think there is a lack of understanding and there's more judgment passed than what we should allow. My dad in 19 years choked 3 times in the where he had to go to the ED. So the airway was partially blocked and he wasn't able to expel it. He had the Heimlich 1 time. I will say he typically did not follow his diet recommendations despite our best efforts, and he did aspirate thin liquids for the majority of those 19 years. And as I said earlier, that's not what he died from, which I consider to be a win. But with that being said, every time my mom went into the ED, including the chicken strip from my 8th birthday party, in which we had to go to a different movie so my mom could take him there, they weren't supportive and saying, oh, I'm sorry you're missing your daughter's party. It was, well, what about this diet texture? Maybe he needs a higher level of care. And one time, Aging and Disability Services even asked her if this was an appropriate living situation for him. Now, of course, I'm biased, but I found her to be a really competent caregiver. And I would say as an SLP now, I would still consider her a competent caregiver. So that judgment that was passed was really painful. And as I said, we as clinicians really have the opportunity to support these people when we may be the only one that cares. And if we're failing to do that, perhaps we're in the wrong profession because that judgment is painful. And I wouldn't wish swallowing disorders, on anyone. This is probably their worst time. So what do we do about that? So I have some insight, as I said, into the challenges faced, and I want to speak directly to the individuals with dysphagia and their families. And as a clinician, I'd like to speak to the clinicians out there as well, that we have to help them take a seat at the table. Now, whether that means a different table, that's possible. Perhaps it doesn't look the way it used to look. And in fact, we weeded out lots of people throughout the years. But here's some ideas to encourage support for individuals with dysphagia, and more importantly, or equally as importantly, I should say, their family units so that they can support one another. So as Samantha touched on, finding your new normal is huge. It sounds easy, but it took us many trials and many different fails in the process. So something I read today, I actually was watching a TED Talk and I thought this was perfect, so I added it in, and we'll have to cite it later perhaps. But her argument was that, people were always trying to figure out why we couldn't move on. You have to move on from this. And the reality is we weren't able to move on. You can't move on from dysphagia, but you can move forward. And I find that to be very important. So as a family, we found a way to move forward. Part of that being that we would establish a routine. So prior to this routine, my dad still loved food, as I mentioned earlier, because it was part of his culture. He continued to want to eat, as many people with dysphagia do. It doesn't go away. People don't stop having the desire for food. And in a culture where food is a big part of our lives, it's still equally as important. So for him, until we found some way that we could make sure he was satisfied in that routine, he did things like taking our riding lawnmower 8 miles to the restaurant on the highway. He also rode down our very steep driveway with a bicycle, and the mailman had to bring him back up. And one time he even got lost in the woods on the way to the restaurant, pockets full of change, ready to go to breakfast. So in finding new routines, we were able to find restaurants that he was comfortable in, with low lighting and people that recognized him, so some familiarity, and they accepted him. And ultimately, if he made a mess, which he often did, they would clean it up. And he felt comfortable there, so he was less likely to choke. And that's a big thing. Stimulation, for choking has a huge increased risk for people with dysphagia. So in establishing that routine, he got Dairy Queen on Thursdays, tacos on Mondays, his breakfast on Sunday, and ultimately he got not 1, not 2, but 3 packets of oatmeal. So as clinicians, if we can find a way to foster that and have people take a seat at that new normal table faster, we can help them exponentially more perhaps, than what diet level they're on, or tucking their chin or turning their head, because this is the stuff they're living. In fact, we went to the same restaurant so often, a gentleman approached my mom at the grocery store and wanted to let her know that her husband had been stealing, that would be my dad, bacon off of his plate for years and eating it. So she would go to pay and he would steal bacon off this man's plate. So we were regulars. Some of the other things we did to modify and help establish that routine was that, you know, any parties or events we had, many of them we ended up hosting. So then if he was uncomfortable, he could go and lay down and take a nap. And if, you know, he didn't feel like having a seat at the large table, he could eat his TV, you know, at his TV tray, and he was still part of the party. We didn't leave him out. He still got to participate with us. I think, did I miss a slide entirely? I think I did. No? Okay. So recognition that people are still human and not just their deficits. This to me is probably one of the most important things. Yes, modifications matter, of course. In fact, when I was in college, I went to a steakhouse with my roommate and I ordered the soup. Okay, so I mean, it impacts the family. And when I ordered the soup, they asked me, you know, why don't you order the steak? And I realized I had never ordered the steak because I too ate a mechanical soft diet. We didn't order steak in my family because my dad was unable to eat it, and often it would end up in his airway. And five-star restaurants, you know, we modified. We found restaurants that were safer for him because five-star restaurants, again, have that added social pressure that you have to be very clean. And when you have eggs coming out of your mouth, that's typically not what they're looking for. So recognizing that people are still human. My dad was included in all aspects of our lives. From vacations, yes, he was in a wheelchair at Disneyland, and yes, we got to the front of the line. All the way through sporting events, I had a special permission in high school to go and pick him up for my sporting events. And often we would barter with him at those events. So we knew the hot dog was going to be an issue in terms of swallowing. So we would talk him into, you know, half a beer with some popcorn instead of the hot dog, and then everybody was happy. And to recognize that what people did before is likely what they still want to do now. So he still went hunting and fishing. In fact, I had a patient once who hadn't been fishing in 5 years because he was in a wheelchair, and I assisted him in finding some companies that he could go out on a charter with so that he could get back to doing the things that make him him. And I think that's really important. So what's key with finding, with recognizing that people are human is that you have to stop mourning what it is that you lost. And that's really difficult to do. But the reality is you have to stop mourning the loss and start accepting what you have left. So my dad, unable to go on a boat any longer again fishing, was able to fish on the bank. And that was still satisfying to him. That's not to say as a family we didn't still have sad days. That occurred, you know, several times a year, but we usually picked up and moved on. My mom being instrumental in that and not allowing us to see him as a person with a disability, but instead seeing him as dad. And to be able to get to that point of acceptance where you accept your situation and who that person is what I hope for every family that I ever work with. With that being said, recognizing that they're human, they're capable of everything that any human is capable of. So any person who has had dysphagia or a head injury or any other, you know, as you would call it, disability, I like to say variance in ability, but they're all capable of the same joy, sadness, irritation that anyone else is. So my dad, being who he was, at times would look at my mom and smirk and urinate on the floor. He was incontinent, sure, but he also was capable of irritating his wife like any other husband, and he would. And instead of pitying him and saying, oh, he has a disability, we'll mop that up, as a family, it was, okay, Dad, now you get to clean that up. There's consequences to your actions. So we didn't see him as someone to pity, we saw him as dad. So quality of life, I think I would keep in mind with this one that, you know, recommendations are just that from healthcare professionals, and they can't be with families every step of the way. In 19 years, my dad was able to find regular solids more times than I can count on my fingers and toes, and he ate them, and sometimes he choked on them, but he was able to expel them from the airway. I mean, there was just nothing we could do about it. The other piece being that with quality of life, I highly recommend that people find humor in quality of life. Because if you can't laugh, things become very sad. So for example, my dad, like I said, you know, he'd have eggs all over his face, sometimes on purpose, honestly, just from eating too quickly. He would look at us and he'd smash them down and they would all bounce around. And then we had to laugh, because if we didn't, it would be very sad. Another example, he had apraxia. So there was a hummingbird in our skylight and he was going to get on the roof to get it. So he climbed halfway up the ladder, realized that, you know, he had apraxia and his brain got stuck, as we called it then. And he ended up mooning us because he was there for so long, his pants fell down. So when we drove up the driveway, all we saw was, you know, his bum. And for us, it became funny. Once we realized he was okay, it was funny. And maybe other people wouldn't laugh at that, but as a family, you have to find a way to find your humor. So my next argument for quality of life is that it's a risk balance assessment for families. And with that, we kind of touched on that a little bit, but so fear, the purpose of fear is if there's a bear coming towards you, it's supposed to be a response so that you run away, which occurred in a hiking trip recently, and it was scary. But that's not the purpose, you know, for your everyday life. That's not the goal. So working with my counselor, a lot of that is trying to feel things all the way through and to rationalize what that would look like. So for example, you know, in my dad's case, it might be, well, he really wants to eat that cheeseburger and he's not swallowing so well today. And so the options are that he's either going to choke on it or he'll be okay. And then you rationalize further, if he does choke on it, how likely is it for it to block the airway completely versus can we get medical attention? And in that way, we survived for 19 years, allowing him to eat what he wanted because he was going to do it anyway, and tried to support him as much as we could. So taking some appropriate risks, if possible, for families, I highly encourage. So mental health, to me, is a really big part of surviving as a family unit and as a person with dysphagia. I think that it's similar to some of the other, you know, I guess you would say diseases out there, in that it can be a really long-standing experience. So people can be dealing with this for a very long time. And you go through the stages of grief because there is a loss of function. There is a loss of, like I said, the chapters are different from what they were to what they are. And with that, you're still mourning someone that's there, which is really tricky as a family member. So if you are mourning that loss, you're mourning what they were and also somewhat what they lost, but you can't really do that successfully because, you know, you don't want to mourn someone that's coming out to dinner with you or coming to birthday parties. So in that aspect, I highly recommend counseling for everyone. In due time, of course, and if that's your thing, but as professionals, I think we can plug here too and say that if people aren't ready to seek professional help, this is where we step in and encourage them to get the assistance they need. So, you know, I mean, I think sometimes maybe formal counseling is a lot for families, and my goal would be that insurance would somehow find a way to cover that. It would be nice to be able to have someone go to therapy and have their family members be able to also attend a counseling session for support. That would be my dream. But again, as a family member of a person with dysphagia, I did have some counseling in school, and she wanted me to stay in at recess, and I didn't want to do that, you know, and she had told my mom that I was so angry it was unlikely that I would graduate from high school. So the effects of, you know, that event and then having someone not supportive, clearly that wasn't my counselor or my person. So my plug, of course, would be to find someone that's successful for you. So as clinicians, some of you may be shocked to hear this, but most of you probably are on board. I don't think that we really can fully understand what people are going through. We can be empathetic and we have the research to support them as they need it, but realistically, we have no idea what that worst day looks like in the acute phases or moving farther out, to months further with dysphagia. So our job, I really think, is to try to make that worst day a little bit better, not just for the patient, but for their entire family. And I have some ideas of what I think we could do. So as an acute care therapist, we have a lot of suggestions, of course, for things that we can do to modify. But I really think we need to take a step back at times and look at the clinical questions. What did this person and their family look like before? Was their relationship healthy before this happened? Did they argue before this? Will they follow through with these strategies? So my dad, as I mentioned, was a bit rough and tumble. He did not brush his teeth regularly, is what my mom told me. And we had a suggestion, from one of our professionals that he should brush his teeth daily, or 2 or 3 times a day. And realistically, that was never going to happen because it didn't happen before. And I think that's where our problem solving as clinicians really comes into play. Because if it didn't happen before, we're sort of setting people up for failure. And then the caregivers feel guilty because they've failed to do the oral care that they needed. And the family members, like I said, feel guilty. And the person maybe does too. But in his case, he really wasn't interested. We did get him to, routine dental appointments, which are difficult with swallowing. We had to find the right dentist who was willing to take the time to work with someone with a swallowing impairment. But ultimately, things like strategies are really only as useful as the buy-in. So if we can't get that therapeutic alliance, if we can't encourage people to do them and it's not part of their social norm or their culture, it's probably unlikely that they'll do them. So again, with him, 19 years, he was alone for every lunch meal, sometimes 2 meals a day, and he was probably supposed to have more supervision than that. So asking those questions of families, like, is it realistic that you will actually be there 24 hours a day? Or are there going to be times when you're not? And trying to assist them with modifications that way. So in his case, we found ways as a family eventually to find some mechanical soft things that we could prepare ahead of time for him. But that was with years of practice and failed attempts where we'd come home and there would be a radish in his airway because they're airway sized, in case anyone was wondering. But realistically, we need to look at our strategies and make sure that we're not setting those families up for failure. So again, as a speech pathologist, my boyfriend jokes that I talk about buying a house in a floodplain all the time. Because I'm from Oregon and I had a professor at U of O that told me never to buy a house in a floodplain. He jokes that I should be an insurance claims adjuster or a risk assessor. And I counter that as SLPs, we already are. So my goal is maybe to focus less on physiology, which is very important. And I'm of course not saying if people are unable, if they're going to fixate, of course, it's crucial. But the focus, like Samantha's presentation showed, is that it's always on the impairment if you have dysphagia. And maybe we need to balance that scale a little bit more with the behavioral approach. So we need to be finding creative ways, which we're good at, of course, of allowing people, to say, I'm never going to drink those thickened liquids. Or in my dad's case, he was going to eat regular solids regardless. So finding regular solids that would eventually melt in the airway. This sounds, again, I cringe as an SLP with the idea that we didn't follow his recommendations, but realistically, we were able to find things like watermelon that he really enjoyed eating that would eventually melt. And I know that's a mixed consistency, but for my mom, that was good. Or ground beef instead of steak, those modifications that we have in our diet levels, but take it a step further and find out what people like to eat specifically at home and how we can modify those things and allow them to have what they want. Or, like his speech pathologist also recognized that he was never going to drink thickened liquids, even though that's what she had initially recommended, and rightfully so because he aspirated thin. But her encouragement instead was to get up and walk. So, you know, to try to limit his risk of pneumonia, to get up and walk and get moving, and to try to encourage him to cough if we heard his wet voice, you know, for us to know the signs and symptoms as a family unit. So I'd tell him all the time to cough because, of course, he had a wet cough or he had a wet voice and he needed to clear his airway. So education, I think something that my goal as a professional would be is to establish a reassessment tool like that, something where if there's changes in these people, because people are living longer with dysphagia, my goal would be, you know, to have a reassessment tool that families can look at as a checklist, like, oh yes, they're coughing more. Oh yes, they just had anesthesia and they're not responding as quickly. Yes, they're aging and they're not eating as much. You know, red flags that we can provide to people long term to assist them in knowing when they need to talk to their PCP about kind of a tune-up with speech therapy. So the tough conversation is something that's big for me. I think my mom had mentioned that she would only place my dad's trach if it was able to come out. And I think what was interesting about that is that, you know, many people would not talk to her about what that was going to look like or what the outcomes for my dad were going to be. So once they placed the trach, you know, preparing her that that could be in for a long amount of time would have been more helpful conversations. So I would argue as clinicians, we should be having those same conversations. Those shouldn't fall solely on the doctor. So many conversations like, this is what your lifestyle will look like if, you know, they continue with this swallowing impairment. And these are some of the things you might face, like that social isolation. And then, of course, my plug for counseling again is that we can be the bridge to other services. So we can see that families are struggling and we should be able to help them reach out and get those resources and support that they need. And as I mentioned, those stages of grief can last a very long time. So what would it look like for us to be able to foster better outcomes or to even have more counseling training in our own profession in order to assist with that grief? Because at every stage in the process, they're grieving something. Yeah, okay. So again, my big take home for us as SLPs is that we are all encountering people on their worst days. Some of these are the worst days of their lives. And we really have the opportunity to give them that seat at the table, to empower them and their families to be able to sit at the table and not feel so isolated and not feel like they're not being heard or cared about. And as an SLP and a family member, I can see where that breaks down at times with our healthcare system. And it would be my goal, of course, to empower them so that they don't have to have those feelings that my family had. And my take home here, again, is that as SLPs and as family members, in our practice, I think it is our goal to assist people to get out and live and to do the things that they want to do. This shouldn't prevent people from living their lives. It may just look different. That's it. Yeah. Okay, questions?
I'll take the other one.
Okay.
Michelle, thank you so much for sharing your story. It takes a lot of courage not only to present a webinar, but to talk about a story that's so personal to you. So thank you both for taking the time tonight to discuss such an important topic to our community. We have a few questions that came in here. One, Michelle, is for you, asking about your father and if you remember how effective his swallow therapy was, and if it made a difference to his swallowing, how long it took, and what that therapy looked like.
It did. So what I do remember, which again, it's been a long time, is that he started out, of course, you know, with the trach and as my journal article showed, he was able then through swallowing therapy to some degree. Well, it's hard, but he went to inpatient rehab, so I know he had intensive swallow therapy there, and we did outpatient it for a short while. But I think what got complicated with him too was that cognitively, he really wasn't invested, and oftentimes he just did what he wanted. So So it was effective, of course, in allowing him to eat again and ultimately get the trach out, which was huge for us quality of life wise.
We had another question too from a caregiver of a person with dysphagia who was asking, what are some tips or strategies that you can suggest for reminding that person how they're supposed to eat if they have certain modifications that they need to do and they either don't necessarily want to do that or forget to do that or are distracted in the moment during a social meal?
So that's a really good question. I think, so like I said, as a family, we found ways to just sort of like preempt that. So if it's thickened liquids or if it's, mechanical soft in my dad's case, we would really only serve foods in the times where we were concerned about his swallow that were already modified to that texture. And reminders, I'm personally a visual person. So oftentimes, even if there's a little cue card that maybe looks like a menu or something next to someone, that can be a really effective visual reminder so that you don't have to keep cueing them, throughout a social meal, because that can be uncomfortable. I don't know.
Yeah, well, and I was just going to add too, we've started to do a little bit of work looking at this idea of behavioral mimicry. So we know that as social beings, we tend to kind of mimic the behaviors of others around us. And so, if someone else is doing something, we're more likely to do that action also. So I've actually also been telling people to give that a try, and I think it fits with your modifications as well. But, if there's, again, if they need to be taking a sip of liquid after every bite of food, do you take a sip of liquid after every bite of food? And sometimes those subconscious cues can help prompt a little bit of that as well.
That's a good point.
I want to return to the question that we asked midway through the presentation about how do you approach the situation when there's family members who disagree on the best approach or who are disinterested in being part of that team.
Yeah, and I think, one thing I will say, and I'm glad Michelle brought up counseling a bit, and also us as professionals being a bridge to other professionals, because, as speech pathologists, we do get training in counseling, but we are by no means counselors. And I think what a great role that we can play is if we do start to notice perhaps some family dysfunction and disagreement, that might be a good time to get other professionals involved as well. So couples and family therapy, those therapists are well trained in how do you deal with a family system? How do you deal with having, the entire family around when they have differing opinions? And so either, seeing if there is a clinician who's willing to work with you, or treat together or give you tips, but I have found it invaluable here at our clinic here. We do work with our couples and family therapy clinicians as well. And I think, at that point, you really need to have that understanding of family systems and family functioning and family dysfunction. And so, I think we can do so much. We can start the conversations, we can gather those opinions, but at some point, I think if as clinicians, we don't feel like we, are able to navigate those differences in the family dynamics, I think that's a great opportunity to try and get someone else in.
Yeah, definitely. I think that was the thing as a family that we probably wished we would have done earlier was, I didn't find mental health support until I was in college. And some people in my family still haven't gone. And I think it could be beneficial for those dynamics between people. I don't know if that's.
Yeah, and I think too, it also, our research had pointed to that family disagreement is a cause or a contributor to caregiver burden. And so I think we certainly don't want to ignore that, and we do want to address it.
Mm-hmm. We have time for one more question. If there's anybody else in the audience that has a question they want to ask, this is a good time to do that. And I think in the meantime, I'll just make one comment. So as a speech language pathologist myself, understanding the impact of dysphagia, I didn't truly understand that until I got to know somebody who had dysphagia outside of that clinical setting. So I think going back to what Samantha said, we look at it so much from this physiological perspective where we see impairment only and we don't see the impact on the person and their family. Getting to know somebody outside of the clinical setting for me has really helped me see the patient and the family unit more than just the impairment. So if there's ever that opportunity for a clinician to get to know somebody with a swallowing disorder outside of their role as that person's speech language pathologist, I personally feel that that's been very beneficial and maybe something that we could incorporate into graduate student programs at some point.
And I think as part of it, it's scary, right? It's scary to get to know people on a personal level. It's scary to ask someone how you feel because you never know how they're going to respond. And so I do think that some of it comes back to training and our own comfort level as clinicians of being okay with that and being okay to say, wow, I really see that this is hard for you. You have a lot going on, and either being able to problem solve it in the moment if you as a clinician feel you have those skills, or again, refer on and make use of those other disciplines out there that could be really helpful for us to be working more with.
Well, and I think too, as clinicians, kind of one of our barriers, just is that mindset that like we have to do what's best, what they're least likely to aspirate. That's what's best for the patient, because that's probably what's safest. But again, with that risk analysis, if that's not what they want, then how can we modify to make them as safe as possible, given that they're also humans and likely to do as they desire.
Mm-hmm. Excellent. Well, Michelle and Samantha, thank you both so much for volunteering your time tonight to give this wonderful presentation. I'm going to turn it back over to Ed so that we can wrap things up. If anybody had an additional question that wasn't answered, feel free to email us and we'll send those on to you.
Definitely. Sounds good. Thank you so much.
Thank you all.
Yep.
I just wanted to add my thanks to Samantha for the structure you gave earlier in the presentation, as well as the quote that you read that really resonated with me. I wanted to thank Michelle for sharing really a very personal story from an early age. And many of the points in your story, I laughed out loud. They're actually very funny. So thanks for interjecting humor into a serious subject. And lastly, I'd like to thank Elizabeth Lipton for organizing this webinar and fielding the questions tonight. And lastly, thank all the participants who joined in for the webinar. Our next webinar is less than a month away. It will be, our keynote speaker will be Dr. Ezra Cohen, Sex, Drugs, and Rock and Roll, the modern day head and neck cancer. So registration for that will be open either tonight or tomorrow. If you had a question that wasn't answered, please email us at info@nfosd.com. And within the next hour or so, go ahead and email with a very brief survey. We appreciate your feedback. The survey literally takes a minute to fill out. It's one page and all the questions are optional. So for our speakers tonight, our organizers, our participants, thank you. And I hope to interact with you again at our next webinar. So good night, everyone.